Good morning. Dr. Neighbor Stevens.
I'm ready to start. Good afternoon, everyone, and welcome to the Black Health Trust weekly program. We're so pleased you've chosen to empower yourselves today by joining us. It's great to have our regular attendees back, and those new to our program, welcome. My name is Barbara Neighbor Stevens. I am double duty today as your hostess, as well as one of the co-moderators, and I hope all are well. We are again talking about domestic violence with different points of emphasis. This production has been co-produced by Dr. Ron Bailey. It is the third in a series, and if it's anything like the first two, you will leave the program with a much higher degree of understanding and appreciation of human dynamics. Dr. Randall Maxey is here. He is our founder and visionary. He is Chief Medical Officer of Advanced Community Medical Care Corporation, and I can't overemphasize the degree to which his personal involvement has led to the success that Black Health Trust is enjoying. Our mission statement: Black Health Trust was founded in response to the coronavirus global pandemic and Dr. Maxey's personal desire to keep his own family safe and fortunate, and for his commitment to informing his tribe. We have now Black Health Trust. The purpose and mission of Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines to offer their expertise and insights into our physical and mental health during these challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioners. Joining Dr. Maxey and myself and Dr. Ron Bailey today is my co-moderator, Dr. Ivan Walks. Now I need to share a few housekeeping items and announcements for this program. This video conference is a live program and is being recorded on different public platforms like Facebook Live and YouTube. Your participation on this program is completely voluntary. And if you choose to participate and prefer not to have your image and likeness displayed, there are visual and audio settings on your personal device that you can use to block your picture and mute your voice. That said, all participants will be muted by our Zoom technician initially. We ask that you remain muted until the host or moderator asks you to contribute in order to minimize the distraction of background noise so we can give 100% attention to our speakers. Check and make sure your device is on mute until called on to speak, and then once again, place your device back on mute when you are done speaking. With regards to the chat room, if you have questions, we invite you to enter them into the chat room. However, please limit your questions to 2 per topic that's being addressed. And please do not use this forum to advertise or promote your products. Understand that there may not be sufficient time to get to all the questions during the call, but we will try to do our best. Chat etiquette. Again, emphasizing 2 questions per topic being addressed. The following disclaimer is required for us to make. Please note that the information communicated on this program is not intended or deemed to be legal or medical advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult their own legal or medical professional for conclusive guidance on how to proceed in your own personal circumstances. We're in this together. If this program has been valuable and interesting to you, please visit the website to learn more about our programming and how you can support Black Health Trust so that we can continue bringing our community outstanding content. Our website can be found at blackhealthtrust.org. If you send an email to social@blackhealthtrust.org, please include your first and last name so that you may be added to the Black Health Trust mailing list. If you don't want to be included in the mailing list, please just indicate that in your email. We want to thank the Black Health Trust Steering Committee, the Executive Board, its virtual administrative assistant, our media production and Zoom technician, Black Health Trust supporters, and all the people behind the scenes for their time and efforts that make this program possible. It's now time for us to welcome all of our distinguished physicians and special guests. We thank you for sharing your valuable time, information, and educated insights with us today. Your participation and support help to empower our communities of color, and this is critical to our present and future well-being as a people. Black is beautiful and knowledge is power. And with that, again, I'd like to welcome everyone this afternoon, and I now turn it over to Dr. Maxey.
Good afternoon, everyone. I'm so happy and pleased that you chose to join us today. And we're expecting a major contribution to your understanding and knowledge of certain things that happen within our communities, not only of color, but across the board. I'm pleased that my co-past president of the National Medical Association, Dr. Ron Bailey, is the producer of the show today, along with my honorable co-moderators, Dr. Barbara Neighbors-Stevens and Dr. Ivan Walks. So I'm so glad that we're here today. We're healthy. We've been blessed. We've been spared. We've gone through the pandemic, and to my understanding, we'll see with the numbers, we seem to be going down in our hospitalizations and our deaths. But we still have a lot of valuable information. We have the long haul syndrome that we're going to be addressing with State University of New York Downstate Medical Center on June 25th. And there's still danger out there. My watchword continues to be use common sense. That is so important in what we do. As we start our program, we had some confusion from the CDC in terms of guidance and advice. And even though we know people are going to use their common sense, I'd like briefly, Dr. Walks, prior to Dr. Neighbor giving our statistics and starting our program, just to speak about what his committee did with coming up with how to take these guidelines.
Thank you, Dr. Maxey, and good afternoon, everyone. Yes, it has been a challenge over the last couple of weeks as guidelines have shifted somewhat from the CDC. Our vaccine and guidelines subcommittee met on Friday evening. I want to thank everyone who took their Friday evening to join the meeting. We discussed the guidelines with respect to vaccines. The vaccine message is the same as it's been for the last several weeks. 12 and over, Pfizer vaccine is available. We encourage folks to take it and to get their children to take it, those who are 12 and over. For those 18 and over, certainly the Moderna vaccine and the J&J vaccines are available, and there are no changes from the vaccine subcommittee with respect to recommending that folks do go out and get vaccinated, remembering that unlike the person I talked to a couple of days ago who was celebrating, I'm fully vaccinated, I just got my shot this afternoon. No, there is that 14-day, that 2-week waiting period after you get your second shot or you get your J&J shot before your immune system is up and running and you can feel that you are fully protected to the extent that the vaccines protect. I know Dr. Bailey would take those 95% papers home from school and somebody would ask him, where are the other 5%? Because 95 is not 100. And
Right,
so
right.
we know that the vaccines are highly protective and highly effective. And at the same time, that's why we still have guidelines. We have guidelines for 2 reasons. 1, because everyone is not vaccinated. And 2, because even if you are vaccinated, 95 is not 100. So we want to encourage people to do what I do. Listen to Dr. Maxey. Let common sense be your watchword. Consider the fact that when you wear your mask, even though we've heard stories of mask shaming, people saying, well, why do you have a mask on? Pandemic's over. Why do you have a mask on? It's not required. We're recommending that folks continue to wear their masks, certainly when they are inside with other folks that they don't know are vaccinated. Wear your mask. And when you're outside, I wear my mask unless I'm walking alone through the neighborhood or something like that, or walking with my wife, I keep my mask on. Going into stores and other places, the mask may not be required anymore. But when you put your mask on, you allow folks who may need to wear a mask, folks that for reasons of immunological differences can't get vaccinated and need to be protected from all of the other folks out there. Wearing your mask is a good example. And keeping that distance. I hope even after the pandemic, long after the pandemic, that we don't do all that close talking. We're right in each other's faces and we do maintain some respect for personal space. So from the vaccine and guidelines committee, we are asking folks to get vaccinated, just as we have for the last several weeks. We're asking folks to follow guidelines that recommend you wear your mask when you're around folks that are not vaccinated, wear your mask when you're indoor in gatherings with people that you don't know for sure are vaccinated. And if you're going out in public stores or what have you, why not? Keep your mask on, whether they require you to have it or not. Again, Dr. Maxey's watchword, common sense. It's not a bad thing for all of us to practice. Thank you, Dr. Maxey. That's what I got.
Thank you, Dr. Watson. Just the other day, I was referred a patient. He was actually a colleague of mine, and he had just tested positive for COVID. And he was sick, very sick. So I said, did you get your vaccine? He said, no, I'm a Marine, I'm an F-18 pilot, and I figured I could withstand the COVID. I sent him immediately to a colleague of mine in Las Vegas. He was referred to an emergency room and got monoclonal globulin immunoserum. And by the next day, he was feeling much better. But the item that I pointed to, he thought that he was strong enough because of his military background. He flies an F-18. What has that got to do with common sense? We all need to know that we are vulnerable. And we also, just before Dr. Barber comes on, we now have our 501c3. And we are an official tax deduction for any of those who think that we are a good value to their communities and their family. We would appreciate your support. Go to our website, blackhealthtrust.org, and look at our pages of information and donate. Dr. Barbara Davis-Stevens?
Yes, Dr. Maxey. I am happy to move us along in the program. You have heard from Dr. Maxey, you have heard from Dr. Walks. I think now we can move to the introduction of Dr. Bailey, who will then lead us in this afternoon's
Do you have your
discussion.
statistics?
I do have statistics. I totally forgot about the statistics. I started to say, is that Freudian, but I'm around too many psychiatrist this afternoon.
You're never around too many psychiatrists.
You are never around too many psychiatrists. You beat me to it. Walks is the guy.
We always review, and I don't know why I was about to forget, the statistics that are provided by the CDC. And as a reminder, we are always a day behind in those statistics because they are posted the evening prior. So as of yesterday evening, CDC was reporting a total of 32,912,150 total cases of COVID in the United States since the beginning of the pandemic. This also reflects a total of 27,596 new cases as of yesterday. And for those of you who have been following along, we have dropped down significantly over the last couple of months. The total US deaths haven't stopped, however. We are now up to 586,335, with 748 reported yesterday. As far as the vaccine administration program is concerned, there have been a total of 283,941,223 doses administered. We didn't capture today, but I will also mention that
Gary Dennis MD.
the CDC is also reporting that there are several states that are hitting significant milestones in their overall total number of vaccines, percent of population that has received vaccines, although we still have a long way to go. Now, why won't my slides advance? There we go. Now, we always like to look at what's happening in our community. And so this is not based on all of those doses that I reported to you previously. This is based on those doses where the ethnicity and race has been attributed. So based on that, this is a smaller data set. It only is comprised of 162,470,794 people. But of those, if you look at the bar that represents Black non-Hispanic, you can see that we have creeped up a little bit, so that of our population, we are around 12% vaccinated, but we still got miles and miles to go. So please, they are trying to make vaccine access easier. They are nationally promoting not just the massive vaccine sites, but pop-up sites. Here in Nashville today, they had a pop-up site at the zoo. And this Sunday is the first Sunday that we've been pretty warm. We've had a very mild, cool spring, but it's now hot. So I think they picked a good day to pop up at the zoo where they can hit families with children 12 and older, as well as adults that have not yet been vaccinated. So that is the story on the data today. And with that, Dr. Maxey, do you want me to move on to Dr. Bailey or go to Dr. Walks? What do you want me to do? And you're on mute, Dr. Maxey. Oh, go ahead. Okay.
Go ahead, Dr. Barbara Neighbor-Stevens. Go ahead and introduce our friend, Dr. Bailey, please.
It is certainly my pleasure. Of course, now Dr. Bailey has been with us on several occasions now. But for those who don't know him, let me please introduce him. Dr. Bailey is a former president of the National Medical Association. He was 113th. He is a psychiatrist by training, having completed his residency training in Texas. And I've never asked Dr. Bailey, but I'm going to make a guess that he may be a Texan. He can correct me if I'm wrong when he,
Out of it.
and he is currently the Chief Medical Officer of the Kedron Community Health System there in Los Angeles. Without further ado, I turn it over to Dr. Bailey.
Thank you very much, Dr. Neighbor Stevens. Very, very happy to join the group today. As Dr. Maxey mentioned, this is our third and final version in a three-part series. Very happy to have been joined by 14 or 15 of my great colleagues in writing this book on intimate partner violence or domestic violence. We spent about 3 years on this. It was published in December 2020. All the listings, I think you'll see a bit later. You can buy it on Amazon, get access to it. The most important thing, I think, is this idea that domestic violence is real. It affects many communities adversely. The data will argue it may be worse in the AA community. African women are by far the single demographic group in gender and race ethnicity most likely to be adversely affected by these considerations, and there's a story to be told. But I think the writing of the book was really more for me and for others. I think it was a chance for us to kind of work together in partnership and collaboration. I think we had a multi-generational, multi-ethnic, multi-gender, multi-geographical group, which I think brought a lot to the table. I also been reached out to by a few persons who asked about how to actually write a book. This is my third book. I did each one differently. Some self-published, some with a company. I was with Roberto Vargas, and another associate dean here at UCLA, drew me yesterday, and he's talking about writing with himself on some topics he's involved in. So I think that information we can share to help all persons, on this show and otherwise, to really grow careers and really think through how to improve the professionalism of those of us in our community, or things we certainly would like to do. The writing of this book, I think, was the process along that line. The specifics of today, I think, are timely, as Barbara pointed out. I have some great speakers. Dexter Samuels, who's a vice president at Meharry. Very happy to have Dexter today. He's speaking with something maybe the most important topic, the aspect of how these concerns affect children and childhood relationships, especially in communities like ours, where there's a disproportionate number of persons who grew up in not only single parent families, but families where perhaps are households that may be in urban communities with a high propensity of a high intensity of population, where you see much more access to persons where domestic violence issues are in play. And to my great long-term friends from the Houston area, Dr. Janice Beal and Dr. Dashiell Guyon. Guyon and I grew up together in Beaumont, Texas area. She'll be speaking about stalking. He'll be speaking about substance abuse. So really, really good group today, and looking forward to the question and answer on this virtual venue, which I think are always pretty excellent. That being said, we can go ahead and get started with the first group. I think I'm gonna speak about teen dating violence for starters. We'll go ahead and get started. As always, we thank you, Kimmy, for our comments. So again, our topic is intimate partner violence, and I began each of these three by pointing out that I talked mainly about domestic violence much of my 30-year career, but appreciate now that the lingo in this business really differentiate IPV, or intimate partner violence, persons you may have an intimate relationship with, who you may or may not live together with, from those who we would describe as domestic violence, persons who you live with and you may or may not have a relationship with. And the demographics can be similar, but the dynamics can be very different. We'll have to go to specifics today to address that. It is an evidence-based approach. We wrote this book like an article in a referee journal. Every page is referenced. Next slide. All right, it's actually a copy of the book, and it's available on Amazon. And thanks Springer Publishing for support. Next slide. We can make this available to all. And here are all our speakers today. Next. So teen dating violence goes without saying. I think everyone listening today is very much aware that certain groups have more vulnerability. I think we're all probably been aware that younger persons early involvement in particularly intimate relationships, teenagers and young adults, especially young women, we're all aware can have in some settings have more risk of dating-oriented violence. As mentioned, I'm going to speak about dating violence, and shortly Dr. Janice Beal will speak about stalking in this setting. Next slide. So overview, clearly children exposed to IPV known to develop negative long-term effects. There's increased probability of teen dating violence and then adult IPV in adulthood. The difficulty coping with emotions and adapting to similar forms of abusive behavior. So very often we make a better pathway, unfortunately, for persons to be abused when these issues start early. And patients can believe that violence is a normal way to resolve conflict. So very often we see a passing down generationally, certainly within the same household, of similar abusive behaviors, behaviors that a person might not tolerate, but someone who they're not involved in an intimate relationship with, even as they're a teen or early adult, they may, if they watched an intimate relationship before them, their parents, for example, engage in violence that's over the top. Violence can be verbal, it can certainly be neglect, but certainly what we very often can see is more direct hands-on physical assault and physical violence. And we also notice that in these intimate partner settings, whatever violence does exist is very often less likely to be reported as mistreatment. Next slide. Comorbidities. So very often, psychiatry is known for multiple co-occurring illnesses. I often comment that ADHD, which we talk about a lot in psychiatry, 40% of the time is co-occurring with another psychiatric illness. So rarely, maybe 6% of the time it's by itself, almost half of the time it occurs with something else. That's actually a pretty good figure that's common, I think, for psychiatric illnesses in general. And you see that here, a lot of overlap. IPV, comorbid, increased risk for clinical depression, as was noted in the Obesity study. More substance use disorders, we're going to talk about that more today with Dr. Guyan. More violence, IPV in adult relationships, more anxiety, more truancy in school, more withdrawal and other school type difficulties, early, risky, non-use of a condom, sexual behavior, and difficulty with future relationships. And by definition, all of these are the types of stressors that very often are known to overwhelm someone's emotional and psychological defense mechanisms, which puts them at risk very often of self-harmful thoughts, including suicidal thoughts. High risk of suicide in certain communities. So we've often have thought that maybe it was less in younger people than adults, older, middle-aged adults, and younger in African communities. But I pointed out, I think 2 months ago, the highest increased risk in the last 5 years of suicide are in young African-American teen women. Still much lower than adults and much lower than Caucasians, but a higher increased peak that's growing. We in the African community should be very sensitive to this and very much aware of this and be able to engage in it and ask these questions early and not think that this is not going to happen in teenage or young adult African-American women, therefore we would ignore it. We do that at our own peril. Next slide. Well, this pictorial, I think, says it all. It points out that very often young women of all backgrounds have angst and anxiety and difficulty in these settings. Very often, I think, as the picture shows me, and perhaps you as well, you can just imagine someone who doesn't know how to get out of a bad situation. Very often, because of intimate relationships, we think that we're to blame, and we internalize the self-construct. We don't leave the situation, we further invest ourselves in it, getting deeper and deeper. We move in with someone, we share money with someone, we share our personal information so that
Are we frozen?
I think we've lost Dr. Bailey's feed for a moment there.
Okay. One of the questions that I'm going to put to him when he comes back, I'm hoping he can hear, is there a difference in the vulnerability of today's teenager or young person than there was, say, 20 or 30 years ago? Are we more susceptible to the issues of being treated badly, so to speak?
I think Dr. Bailey's back.
Yeah, I'm back. Sorry, I think we lost connection. But if I heard the end of Dr. Maxey's question, I'll go and answer it. I mean, the reality is we really don't know. Many would argue that the numbers are higher. That's difficult to debate. But I'm always conscious and cautious in my profession of lack of reporting or underreporting in our community for just these basic reasons. It's really interesting because now, as I think Neighbor Stevens mentioned earlier, we should discuss what's kind of happening in the current marketplace. And I think the ideas have grown that there's more civil unrest, and we're thinking and talking about issues much greater. But one issue I think that has not changed is that in AA communities, often families have been very reluctant to call law enforcement or the authorities for fear that they may actually bring more violence and bring more heat, quote unquote, to our community than otherwise. If they come, the dog is to hunt rather than to protect. So I've
That is
always wondered,
correct.
perhaps this is greater in the past than we were documented because of cultural issues, cultural concerns. So although it's a good thing if we're getting more reporting, we want professional intervention to limit risk to our women, to all women really in this regard. It's not only women, but primarily women. But I'm always cautious of arguing that we're seeing more of it, because that implies, and some of them argue, can we go back to the good old days? So back when we didn't have these things. And I'm not sure the good old days were all that good for many people in our community. I think there was probably a lot more violence and disagreement and disgruntlement and unreadiness and conflict that maybe we were aware of. Perhaps we're doing a better job on the science side now, Dr. Maxey, being aware, being descriptive, and making an argument, making these issues public so we can actually intervene.
Thank you.
Next slide, Emmy. Next slide. So statistics, 13% of men, 20% of women have been an aggressor in these teen dating violence circumstances in these early high school years, age 13, 14 until about 16. The CDC in 2019 found about 1 in 11 females and 1 in 15 male high school students experienced some physical dating violence. About 1 in 9 females and 1 in 36 male high school students reported experiencing teen dating violence in the last year, reported by Morning. So older adolescents experience more teen dating violence, about 2.5 to 4 times increased risk of other problems, more use of cigarettes, tobacco products, more use of illicit substances and toxic substances, we'll speak about that more today, and drinking alcohol. So teen dating violence very often mirrors difficulties and other aspects of how teens function. And I think it very often stunts their emotional development as well as the physical as well. Next. Treatment goals. So in these settings, we have a 3-point plan. You have to kind of address and identify and diagnose and get a background for starters. You have to kind of make some recommendations that we think are culturally appropriate, and then follow up, I think, is going to be key. We note in the slide that one should curtail the impact of IPV in adult relationships, because that halts the cycle of violence of future generations. We should and must intervene. We should not ignore these issues or underplay them, because they'll just kind of pan out. One unfortunate strategy very often by professionals may be simply to tell the parents. If the parents are exhibiting the exact same or experiencing the same problem, then whether it's their fault or not, intentionally, unintentionally, they're kind of causative or something correlative in the overall problem, because the young teen is seeing this as a normal measure of how in relationships should exist, and they should not. We also know that patients very often are filled with fear and distrust. If you're watching two people who should be loving and protecting each other, whether it's your parents or older relatives in that setting, and they're engaged in really significant physical violence, why wouldn't a teen or a young adult think that who can you trust? The persons who should protect you are the ones who are harming you. So very often there's less transparency, as I mentioned earlier. Very often is either less or ineffective communication in these settings, because I think teen dating violence very often breaks down many of the typical foundational structures of how a relationship should start. It should start with trust and safety and protection, and then move on to more effective actions, including intimacy. At the end, the goal in treatment is to create a strong rapport or to build trust. It's vital and it's essential. And when you don't have it, you undermine, I think, what's needed for the building of strong relationships. Next slide. Strategy to prevent teen dating violence. We should teach safe, healthy relationship skills from social emotional learning programs for youth. I think we should engage earlier. I think someone said on this show before, I thought of my whole career, we should probably teach psychiatry or psychology as an official course. I mean, it's somewhere in high school. Some would argue maybe in 8th grade before you start high school, because some of the behavioral difficulties that exist have an emotional, psychological impact, and we actually address them once there's a problem. We don't get ahead of the ball game as we do in education and teach normative how things should be well in advance. earlier in my high school years, 30, 40 years ago, they teach home economics. And the concept was to teach somebody how to function well in that environment. They may not teach that directly anymore, but the concept remains the same. There's a lot that people can learn in schools to give them a fighting chance early on to not have any of the problems, such as teen dating violence, that can occur otherwise. We also know the strategies, including influential adults, men and boys, so it can be allies prevention. We talk a lot, even myself, I try to say everybody, but often I'll say women more likely than others. But the reality is we should be teaching boys and men, everybody as much as teaching young adult women and young women about these issues. They should be mindful of them. They should be mindful whether they are the perpetrator or a group that may perpetrate these actions, or whether they are potential victims. Boys shouldn't be afraid to acknowledge that there are victims in this setting as well. We should also disrupt the developmental pathways that are problematic leading toward IPV. Sometimes, as I mentioned earlier, the parenting skills are lacking, and that's where the difficulties occur. So there should be better family relationship programs to bring groups in and kind of discuss these issues. And historically, I think churches were a good setting for such. I think professional entities can be as well. We shouldn't take for granted that persons have been raised correctly, quote unquote, or understand what they should do normally. It's like persons learn to, smoke tobacco or drink alcohol or engage in other behaviors because they watch somebody older than them do it. I think they see the same thing, I think, in many regards in teen dating violence. So we should create protective environments that should be safe of violence. And we also should strengthen the economic supports for families. It goes without saying, the more likely somebody is limiting financially and economically, the more overall risk they may have. What if you were a teen, young man or young woman, and the main time you got to kind of go out to dinner was on a date? If you didn't do it with your family, or if your family didn't buy you new clothes, or if they didn't treat you to certain perks that you like. I mean, every teen wants to go to a concert every now and then, or some event, or to a movie. If you only get it when you're dating, and that dating becomes risky or violent, one reason why you don't tell or end it is you may lose some of the fiscal benefits that actually come along with it, or the economic benefits. As unfortunate that may be, I assure you, we said a lot in psychiatry, and we should think about it. And finally, we should do all the things we can do to increase safety and lessen harm. Next slide. So in now, thank you so much for that discussion. We're going to move on to Dr. Guyan. Again, I mentioned I've known Dr. Guyan for a long time, longer than he probably wants to mention. But the reality is he's a great guy. He, I think, runs the substance abuse there's an office out of the mayor's office, Svp Protocol in Houston. I can talk about that piece. And they're doing a lot of work up in this area there. Very happy to have him on the chapter on substance abuse and on today's program. Dr. Guyan. I think we have a question from Dr. Jewett. You're on mute.
Yeah, I'm on. Can you hear me now?
I hear you now.
Yes, yes.
Okay. I agree with your list, but one thing that's missing is molestation. And the majority of our patients give a history of being molested. And I personally think that is the biggest problem in the Black and minority communities. I'd like your comments on that, because I think it's very hard to get young people to do other things when one of the real problems has been that mama's boyfriends have molested them. Uncle Joe, stepfather, etc., has molested them. And when you're molested, when you're 8, 9, 10, 14 years old, that stays with you. And until you deal with that, you can't expect some of the other things to correct itself. Thanks.
No, you're right. So it's very, very much a timely point, and I think that's a thread that's going to run through all of the discussions today. The reality is there are aspects of persons' lives that make some more susceptible to the risk. I was beginning to speak about that a little bit in regards to teen dating violence, when you lose the economic benefit of going on dates and getting new clothes or going to a movie, things of that nature. But I think you're 100% right. Even before you get to the point where you're dating, that's the case. If you've been molested at these earlier ages, sometimes not only preteen, but pre-adolescent, preteen, but in the younger years, even pre-childhood, 6 to 12, if molestation is happening at 3 and 4 and 5, let alone 7, 8, 9, or 10, that child's a remarkably great risk. I think it's also true that that creates this lack of trust that we spoke about, but also I think creates this concept that you have to have love and express love in this more mature, intimate fashion to be treated fairly. to be safe, to be protected, and things of that nature, including molestation, whether it be sexual abuse and touching, or we very often call assault with actual penetration, either digitally or with sexual organs, puts many of our young persons, especially our young women, at grave risk. I thought to kind of comment on Dr. Max and comment about how early these things happen or what our numbers show. Our numbers all over the place. I've seen numbers as low as 10 and 20%, which I think is not at all correct, to as high as 80 to 90% in some settings, some communities, of how many young persons have been sexually molested. So I think this idea that there's a much higher risk is great. And if you can imagine for your audience, like Max saying, of all the issues that are probably less likely protected, not only then do you have the young person not wanting to tell or inform or kind of blow the whistle. At times you have the third person, which may be the adult woman in the household. If there's a man doing it to a younger child, or after a younger girl, maybe an adult woman who finds herself perplexed because that adult man may be the primary breadwinner. So not only might that adult man physically hurt her, he may also be the one that if he goes away, they can't pay the rent. So these issues put, I think, many in our community at extreme risk. And it's quite a conundrum very often for those of us in organized medicine to find an appropriate and effective strategy. I would end it by saying safety has to be our priority, though, and we have to find ways to provide safety for our children.
And my comment as you move on is there a deterioration of the family structure in our community that leads to children not being safe mentally, children not being safe among friends and family? And is that related to our family structure? At some point as we go on, I'd like that addressed.
Yeah, got a lot of ideas about it. I may punt that one briefly and let one of my co-panelists address it. Janice may want to take that one a bit as well. I think it's very clear, though, that there have been some substantive operative change in our society over the last few decades, let alone in the last 12 to 15 months with the COVID-19 crisis and all of the social distancing. There's more people at home a great deal, which also puts them at a greater risk, I think, of in-home violence. We discussed that, I think, last month, and I think that the more we dig, Dr. Maxey, the more we're finding what we don't want to see. I think there's more risk. I think there's more violence toward young person, more abuse. Teen dating violence, what this discussion was about, really just kind of, I think, pull the Band-Aid off the wrapper a little bit and give us some reasons to see it. But no doubt about it, I think that the numbers are adverse. I mean, I work at an inner city hospital here in Los Angeles. We have people with SPMI, some of the sickest patients you're going to have in downtown of a major city. And often the question is not, how much do we have, but can I find anybody, Dr. Maxey, who these issues of prior abuse does not exist in? I mean, it's rampant in our communities. We have a whole huge homeless population as well. So you put on top of homelessness, it really worsens the issue of concern. I think I'll stop and move to Dr. Guy. You made some comments about that, and we get show his slides on substance abuse. But very, very good points. I want to make sure we address them today. Dr. Guyan, I'll give you the floor.
Yes, thank you. Good afternoon, everyone. We were trying to work out some of the technology here. Multitasking, I'm not sure if you could see me. I think I'm okay now. I am at work, but I'm on my lunch break. But I'm excited about here. I'm honored to be able to present before the Black Health Trust. Dr. Bailey has spoken so much about it, and he and I, as she said, go back several years, and proud to be his friend, his fraternity brother, homeboy, whatever you want to call it. But anyway, I'm going to spend a few moments this afternoon talking a little about substance abuse and intimate partner violence. And it's a lot that we could spend, a lot of time we could spend on this, but I'm only gonna, I think they told me about 15 minutes, so we'll try to touch on some of the main points. Let's see if we can get to the first slide. Let's see, there we go. Okay, so we know that substance abuse is very much a part of our society, and it's very real. It's been here and it's going to continue to be here. It's growing more and more. I was just listening to the news this morning, and they said tonight on the newscast, they're going to talk about Delta 8, which is a derivative of THC They've changed, I think, one or two elements. And so, you know, the whole industry of cannabis is a multi-million, maybe even a multi-billion-dollar industry. It does have an effect on human behavior. And that's primarily what I want to talk about from a behavioral scientist perspective, you know, is the effect that it has on our behavior. And, you know, knowing that it is a psychoactive chemical that alters oftentimes the way we think, the way we perceive, the way we react to certain situations. And it's not difficult to see where this is, it has an impact in so many aspects of our lives. Any given day we can cut on the news and we can learn about something that is tragic that has happened. And somewhere in there, there's going to be something associated with either drugs and or alcohol. So we know that not only does it affect people in intimate partner relationships, it affects so many other things. And in the article, I went back and found some information that talk about a parent who sold her child down in Corpus Christi to pay off her drug debt. There was another one where there are employers who are looking for people to work, but they can't pass the drug test. So we know that is very much a part of our society. Let's see, next slide, please. So in my introduction, these are just a few statistics that I were able to gather. We talk about the different types of drugs, as you can see, the major categories, all of which have an influence on human behavior. And as I said, there's a growing trend in our society about legalizing marijuana and the use of marijuana for both medical and recreational purposes. It's not uncommon. We're seeing more and more of it. And then the last one I was able to see from the CDC suggests that 29 people a day in the United States may even die of motor vehicle accidents that are involved in alcohol. So again, it shows the prevalence of drugs and alcohol in our society. Next slide, please. Again, these were just some more factors I was able to find. As I mentioned before, the incident that occurred down in Corpus Christi, companies that are looking for people that to work, but they can't pass the drug test. And even the fact that their violent behaviors, which are more often to occur when people are subject to using drugs like methamphetamines, and we'll talk a little bit more about that. Next slide, please. So if we look at the difference perhaps between substance abuse and substance use disorder, the definitions are such that substance abuse are as harmful and hazardous as any psychoactive drug substance, including alcohol. What we are concerned about also with regards to that is self-destructive and generally includes dominating desire to continue to use the drug despite the harmful consequences. This is what we see a lot of times that's associated with the substance abuse issues. We do have individuals who, again, have been stopped with DWIs. They have had other related kind of problems. It doesn't stop. They continue to use it, even though it has caused quite a few legal issues for them. Next slide, please. And of course, the substance use disorder, based largely on the work of the DSM-5. And we know that a combination has an effect on us cognitive, behaviorally, emotionally, psychologically, and physiologically. And it interferes with our ability to function. Basically, we're talking about a level of dependency here where it's what's needed in order to be able to just get through life and get through everyday functioning. I just got out of a group therapy session just minutes ago. And this is with a group of patients here at the hospital. where many of them are indeed dealing with these substance use disorders. They're engaged in addictive type of drug behavior that with regards to their reward system, and of course, trying to help them understand how it floods their circuit and their dopamine. But part of this with the substance use disorder is just helping them to understand what it actually is going on with them. Next slide. Again, this is just additional information that we were able to gather regarding to substance use disorder, much of which has been supported by the DSM-5. And we do know that those people who suffer with this level of dependency, it interferes with their behavior, their personal life, their behavior to attend families, work, school, much of what we see even right now here in the hospital. Next slide, please. Okay, so given the fact that we know the impact of drugs and alcohol, talk a little bit about what influence it has on the person that's in the intimate partner relationship. Now, let me preface this by saying two things. One, we're talking about the person who's the victim in the intimate partner relationship. Statistics suggest that it's usually in a heterosexual relationship, although it can be in same-sexual relationships. It is generally a female that is usually the victim. And so those are, oftentimes the demographics that we see associated with it. Now, what I was looking at here is that victims will often resort to the use or abuse of drugs if they're in an intimate partner relationship. Now, it's important to understand that drugs and alcohol do not cause that to happen. I mean, any of these things can contribute to intimate partner violence, but this is oftentimes based on the research and the data we've seen from a clinical perspective. It's the individual that uses the victim. They may use the drug as a means of escape. Alcohol and drug alters the state of consciousness. It eases the physical, emotional pain that they often experience. Next slide, please. Again, these are more characteristics that we see that's associated with the victim and their use of drugs and alcohol. They can be coerced into using the drugs and alcohol as a manipulative type tactic. The individual, the perpetrator, who is the aggressor, will want to persuade them to be involved with it, that it's okay, this is the way we do it. And, there are other psychological factors that's associated with the victim, perhaps that will allow them to succumb to this. The victim may be led to believe that such activity will help even strengthen their relationship. I've seen this a lot in the treatment and working with them, where part of their relationship is let's get high together, and so that helps to create a bond, if you will. Now, the other variables that I think are so important that I see taking place, particularly with the victim, is a sense of low self-esteem. There's poor self-concept, a lack of impulse control, often associated with those individuals and their use of drugs and alcohol. Next slide, please. On the other hand, we have the perpetrator. This is the other person. This is the aggressor, if you will, a factor that contributes to the aggressive behavior, use of alcohol. These chemicals can change a person's perceptions and reality. And as colleagues who work in the field, and Dr. Bailey and I have talked at length with regards to perceptions, and we know that the use of drugs and alcohol can cause less inhibition. in my work at the university, in working with college students, and even in working and teaching with them, what we have seen incidents where there have been cases of rape. And of course, I work closely with the individual, the person who is the coordinator for domestic violence on campus. But the fact is that under the influence of drugs and alcohol, things that you normally would not do, it gives you confidence to do. And even to the point to, it's kind of even, let me say, how can I share this and make it sound right? I don't want to say, well, let's say it's kind of glorified, if you will. I hear a song on the radio, and this is no judgment against the person himself, because I am a Jamie Foxx fan, but they will talk about blame it on the alcohol, so we know that it can have and cause less inhibition, cause poor judgment, irrational beliefs, and weak impulse control. Let's see the next one. And again, these are characteristics that I see and the work that I've gathered that's associated with the perpetrator. The alcohol and drugs, cocaine, and methamphetamine, cocaine and overstimulates, of course, the nervous system. These are what we're saying that can cause them to feel less inhibited from a neuropsychological perspective. Could cause an individual to become impulsive, aggressive, anxious, and exhibit a sense of power and control. Because sometimes what we have been able to find is that those individuals who would have not had that sense of power and control, once under the influence, they turn into a whole different person. So it does have a change and an effect on the personality. And whereas if they were in a relationship and they were approaching the victim is resistant to engaging in any kind of sexual relationship. And now I'm under the influence, and oh yeah, you're gonna do something tonight. Whereas in another situation, had he not been under the influence, the likelihood of that occurring would have been less. Let's see, you got one more on there. Another slide. Okay, again, these are just additional behavior characteristics that we see that's associated with it. Unfortunately, we do see it where the perpetrator, so there's psychological issues on both the victim and the perpetrator. Perpetrator drug abuse may become coupled with behavioral characteristics. So they may have some other factors that are going on. I see a lot of it with oppositional defiant and even some personality disorder type characteristics. They too may suffer from self-esteem and poor self-concept. They feel like that's the only way they have a sense of control. They may be easily intimidated and so, not feeling very confident about themselves. They have extreme needs to maintain power and dominance over their partners. This is what we found oftentimes in the literature. Alcohol and drugs help to support that. And moreover, the males with personality disorders such as narcissistic disorders may be more characteristic of IPV perpetrators. Another slide. Oh, okay. So we're pretty much at that point. I know I only had a short time to spend with you to discuss it. We could have gone, of course, much longer. Dr. Bailey, would I open up for questions now, or how you want to do that?
Yeah. In fact, if I could ask a question first, I'd appreciate it. First of all, thank you for your very astute presentation. I'm an internist nephrologist in Inglewood, California, and I may be guilty with my alcoholics. I say, I'd rather you smoke weed than to drink alcohol in terms of level of toxicity. And I also have a number of patients who are taking pain medications like Narco and other substances. I say, well, CBD or even THC are better than that. Am I making a value judgment? How would you look at the dangers of those various things? And is there any such thing as casual use of THC or CBD that's not substance abuse disorder?
Well, I appreciate you sharing that, Dr. Maxey, and that's often a point of debate. I get the patients, and of course, my background in training in clinical and counseling psychology, and we've learned to yield to the psychiatrists because they're the ones that study medication. We're focusing more on behavioral change. Now, with that said, when a patient approaches me with the same topic, my response, if your physician says it's okay and willing to monitor and follow you with regards to that. So if you're using it, let's say for medicinal purposes, then I have no argument. Okay, I have no argument. What my concern is, whereas these people are using it to the point to where it's recreational, it's out of control. And even more so, what I'm concerned about, as I even spoke with them earlier today, if you have a pre-existing condition, such as what I'm seeing here, a lot of schizophrenia, schizoaffective, bipolar disorder, and then you're using illicit drugs to self-medicate, but you will not use the antipsychotics that your psychiatrist have prescribed for you. Well, my analogy of something like that is, if you're a diabetic, why eat sugar? If your physician says, okay, I'm gonna write you a prescription and you eat sugar, okay, that's between you and your physician. But as a therapist, working with the patients, my objective is to try to help them improve the quality of their lifestyle. And if this is not regulated by a licensed physician, then I oftentimes discourage the use of drugs, even, the casual use of marijuana.
Thank you. Dr. Bailey?
I think, let's see.
Yes, and next we're going to go to Dr. Janice Beal, Stalking.
I think there was another question, Dr. Bailey.
I'm sorry, Dr. Jordan had a question.
Dr. Jordan had a question.
Okay, can you hear me?
Certainly.
Okay.
Yes.
Back to your topic about the perpetrator. I have 3 patients right now, and I'll talk about one. He will not date your daughter unless she has a daughter who is between 12 and 14.
Oh, Lord.
What turns him on is for her to walk in and catch him screwing her daughter.
Oh,
and
my God.
And then for him to convince her that it was the daughter's fault. And literally, when he explained that to me, he had an orgasm. My point, I've had several patients, this is not just you get to this point and this is where you stay, but they become experts at it and they take on new roles in terms of how to have sex with someone. So I just like to have someone look at that. It isn't just that they become a perpetrator, but as a perpetrator, 15 years ago, they did only A and B, but now 15 years later, they're doing the whole damn alphabet.
Oh,
and
wow.
they're much more experts at doing it now and have no conscience about doing it.
So you're talking like a pedophile, Dr. Jordan?
Well, they can be pedophiles. It's just that that's their ego.
Okay.
They consider it a challenge to do things, but it's that they learn. The first time that didn't happen. The second time that didn't happen, but now 10 years later, that's what they're doing. And when we get them, first of all, when we get there, I don't think we've had 5 patients in my whole 40-year history of treating AIDS patients who came in with a doctor, period. We're the first ones to see them. And so we've had to find someone to see them.
Let me just jump in, Dr. Jordan. I think one, as a psychiatrist, and two, as a former member of a state board of education, I think we have to be very careful about where that line is in duty to report. If someone is intentionally having a 12-year-old to 14-year-old walk in on them doing a behavior that children should not see, that's in the child abuse category. And I think the question that you're asking is a very important question. People have all kinds of habits. I think we as physicians and we as professionals of all kinds have to be very careful about our duty to report when someone is endangering a child. I'll just add that. Sorry.
Yeah, no, I agree.
Mr.
Excellent.
Ron, I'll jump in as well. It's a different topic, but I spent about 9, almost 10 years on the Svp Protocol in Texas, which is the law that allows for the involuntary civil commitment of sexually violent predators, persons who engage in, as Dr. Jordan points out, all kinds of behaviors that many of us may think are non-traditional and untoward. But I think, as Ivan points out, very often they do cross the line, you're right, Ivan, into what's reportable, I think, for us as professionals. But I think Dr. Jordan's point, they also, I think, emphasize that, persons have all kinds of thoughts going between their ears. I'm often share that, if you want to have a cocktail party, don't invite a psychiatrist, because we've heard all of the stories. And very often Ivan laughs, they make you afraid of the thoughts that are going through people's thought processes, even you think in regular everyday polite conversation. That person, told you that story. So very often as physicians and clinicians, you hear that story, and this is shocking. I think it probably is less shocking the more you hear it. And the decade I spent in that business, I think I began to have my sensibilities dulled, so to speak, because there's so many of those kinds of stories. So many people, I think, Dr. Jordan, who, as you point out, I think correctly, have what many of us might think are adverse comments or thoughts. But that is what, as you said correctly, what turns people on, or what may actually lead to what was necessary to complete the sexual act, the orgasm. And also, I think, very often, unfortunately, can lead to aberrant or even illegal behavior. I think to the actual Guyon's point, substance abuse or alcoholism, particularly, for example, other forms of toxic substances, disinhibit a person. And there's a point that Guyon was making, the disinhibition on top of these earlier thoughts that society says are non-acceptable is this volatile combination. And the third point I'll end with, when you're in a setting where you're not protected, when your biological relative, your father, for example, is not there, send out signals that I will kill you if you touch my child, very often it's an easier end. So many of our children and younger adults and younger teen women are remarkable vulnerability in these settings. And I think that's why this issue of IPV has a great importance. I know Dexter's going to end after Janet speaks, talking about what happens to children in these settings. So I'll stop at this point. But it's a remarkably important point. I'm glad you brought it up. Dash, I'll come back to you to finish before we go to Dr. Beal.
No, that was it. I'm ready to conclude. I mean, I appreciate, again, the opportunity to share this information with you, and I hope that it's been helpful.
Thank you, sir.
My good friend, Dr. Beal.
Hello, everyone. Good afternoon. Thank you, Dr. Guyon, for talking about the substance abuse component. And Dr. Bailey, thank you for having me this afternoon, along with your distinguished colleagues. I have the opportunity to talk about, in my section, on stalking. And stalking has a history of where, at one point, like in the early 20th century, that it was something that only women did. And it was a part of what we thought was a delusional relationship between the stalker and the star. Or the famous person. So the term stalking has had some changes and come to where we're actually dealing with today with the everyday relationships that people are having. Because at one point, when it was a female that was stalking the important person, and then it went through to the 80s and through the 90s was when we first started to really look at stalking as a part of a relationship and a part of domestic violence relationships. So as it made that transition is where we are today, talking about relationships and intimate partner violence as far as stalking is concerned. Next slide, please. Okay, and as you can see, this is a vivid description of someone who's afraid. Because if anyone who's in a relationship with someone or trying to get out of a relationship, if somebody is stalking them, it creates a certain amount of fear that's not only psychological, but physical harm is a process of what could take place as well. Next slide, please. Okay. It's important that we ensure the victim's safety once they try to escape or get out of a relationship. It can also cause feelings for an individual of not having autonomy, being associated, and their privacy is taken away. And it often leads to where we know that it's taking place more so in violent relationships, or people, there's a lot of abuse that's in the relationship. And so the stalker feels like with anyone who's trying to maintain control in a violent relationship, they're losing control. So as this person is losing control, they have to try to figure out what can they do to maintain and keep that person as close to them as possible, whether they want it or not. And so perpetrators of abuse use stalking as an emotional and a psychological tactic. So which means that they're going to try to play on everything that they know about that individual in order to keep them to become, or to remain or still be a part of who they are. And so no matter how much we're trying to break away, or they're trying to break away from that relationship, they're looking and they're trying to use everything imaginable. Next slide, please. Okay, so it's a part of the attachment theory. And remember the attachment theory that we first started talking about, but the psychological model that's useful in understanding stalking behavior is the fact that it's a dysfunctional development in an early interpersonal relationship. So very in the onset of when that person starts to, or those two people start to develop that relationship, somewhere along the lines, it becomes dysfunctional, because attachment theories mean a person cannot function without the other individual. And so they start to focus on how people respond and what could hurt them. As they get to know each other, you know, they start looking and finding things to make sure. They make statements such as, I can't live without you. Okay, that you're the most important thing, you know, in this world. So not only has it starts to progress from what we consider to be a love type relationship to where it's unhealthy, that if you're in a relationship with someone who makes that statement. Because I tell my patients that if someone says they can't live without you, that's a first warning sign that it may not be the best relationship for you. Because that means that person's going to do whatever they can in order to make sure that you're within that relationship. And that's making threats of, for lack of better terms, I'm going to commit suicide if I don't have you. I need you. Our children need each other, and just all types of words, whatever word choices they can find in order to make sure and to maintain and hold on to that relationship between each other. It's usually an attempt to, like I said, to gain proximity to the victim and somehow strengthen their relationship of not being deterred. Next slide, please. In the event also, and hopefully I'm not running too fast through what I'm talking about. Control is all types of control. We have psychological control, where a person's controlling a person's mind. We have physical control, where they're trying to control a person's ability to be able to move and to do certain things, as well as financial restrictions. Most people who are attempting to stalk an individual, if they still have a certain amount of control over that person, they try to financially restrict them from doing things or terminate their ability to be able to support the family, and using that as a way of keeping that victim within that relationship. And if that doesn't work, then that's when the section that I just talked about of threatening suicide, or threatening to hurt themselves, or threatening to hurt that individual. If you leave me, this is what will happen to you. Or I promise that I will not be able to leave or live without you. And we're talking about stalking starting very early. We're not necessarily talking about adults. We're talking about starting as far as teenagers that are in relationships such as this nature. And when you have a teenager who's in a developmental stage that can't quite really understand, you know, trying to break away from their parents, or trying to listen to their friends as being the people that are controlling them or helping them to become who they think that they want to be, they're listening. So developmentally, they're not capable of making a lot of the right choices and letting someone know when they're in a relationship that feels unhealthy, and the person is attempting to control their movements and attempting to find out everything that they're doing. Now, one thing that I have heard twice in some of the questions was, you know, has there been a change in how we are looking at domestic violence and relationships from in the past to where we are today? Well, the change has been the fact that technology has played a whole different part of of what people were able to do or are able to do, because now we have cyberbullying and all the other things that teenagers are very well versed on that helps them to be able to find out what's going on. My daughter is an adolescent. In her group chat, they have a section where they touch where everybody knows where everybody is at all times. So, which means that if that person has access to that individual's cell phone, they can put that on there without them actually knowing and being able to track the phone and track their location. So it's a good thing, I guess, at one point, but it's also a bad thing when it's used inappropriately. Next slide, please. Okay, so it's almost like being in bondage. Do we lock down their brain? Do we lock down them physically? You know, once you control a person's mind and you control their thoughts, you know, the psychological chains are much heavier than the physical change. Because if I can control your brain, I can control everything about you. So if I put that certain amount of fear into you, and I have that certain amount of fear into what you're able to do or what you think that you can do, then it controls that person's actions and their behaviors. And so when we look at young women, and we have a lot of statistics on women who are under the age of 25 and who are in relationships that feel as though at this particular time in their lives, they cannot do without that person, or they cannot do anything because that person is in control and they think that person controls everything about them. Next slide, please. Okay. One other thing that we just finished talking about was drugs and alcohol. So let's say that we can't pretty much, or they cannot control the person just by talking to them and telling them certain things. So if we get them addicted to drugs and alcohol, then that becomes another form of dependency. That becomes another way of people looking at that individual to be able to control them. So it's all about control. It's all about being able to maintain a certain amount of ability to have that person need them and to be in their life, whether they want to be or not. Physically or sexually assaulting the victim, the perpetrator can often derive from the victim's consent or decision-making regarding matters of their own body, their life, their work, acquaintances. I've been practicing for quite some time, and I've had a lot of victims who have come in. And even though they didn't use the term stalking, the fear that the person who they were trying to break that relationship up definitely fell into this category, because of the fact that they thought that they could not move or they couldn't do anything, and they were afraid even to go to work. So we started doing different ways in order to get to work, different routes as far as them traveling to go to work, so the person wouldn't know the direction in which they were going in. Trying to have the coworkers be on the lookout if he were to drive up, because we had the cars and the police involved, and the police can't be there at all times. It's not until something actually happens or the victim actually does something to them that we can actually file charges. So that made it really, really difficult. They could put, of course, a restraining order on the individual, but to keep that individual from actually doing something they had to be caught in the act. And they had to be something to where we could actually call the police because they were there doing certain things. So throughout years of actually helping women get out of these situations, it's been quite difficult. It's because the stalkers have become very sophisticated. And if they're adolescents or teens, you know, the most important thing would be, you know, on cyberspace, and we can actually go back and track things now that we couldn't do in the past. So these years of trying to help victims has been pretty challenging. For safety reasons, and breaking the psychological bonds that they had on them has also been challenging in talk therapy. Next slide, please. Okay, so our central theme is to promote social isolation, inhibit the victim's reality testing. So the reality of the victim knowing that they're in an abusive relationship and they really are stating that's not a healthy relationship. And it's kind of hard to, when people don't know what's healthy versus what's not healthy. And so when you think and you start, I guess, working with them and talking about things that, well, does it really make sense to, if somebody's not letting you go to the grocery store without calling them first, or if you have to ask in order to pay, to get food for your children, is that a healthy thing? Recently, as Dr. Bailey mentioned, I served on the mayor's domestic violence, along with the Congresswoman Act that we recently had. in Houston, and we saw an increase in domestic violence, and we saw an increase in the numbers that were being reported, because now for the first time during that pandemic time period, people were at home with their families and had not spent that much time together. So when they realized how they were in those relationships, that increased the use of substance abuse, as well as people not having their jobs. And it also we saw an increase in violence among children. So violence along the whole spectrum increased for us over this past year. And that's pretty much people of color. And that's Hispanic and the African-American communities and the Asian communities, which we were getting the largest, most reported. So all the agencies here in Houston started to come together to offer services to let them know that there was a way to get out of these relationships and to make sure they were able to go to, we realized we didn't have enough at that particular time period, safety spaces for them to go to. So we saw an increase in that as well. So, and because of the fact they were being stalked by their victims if they decided to leave, or they felt as though they couldn't leave. And financially, there was a lot of deficits that people were having during the pandemic. So overall, there was a major, major increase in our city and across the board, because I looked at nationally to see what was going on as well. So, intimate partner violence increased. And I'm sure once we actually look at those statistics and get those final numbers, we'll see that it was much higher even than what we're anticipating or thinking that we have. Next slide, please. Okay, so mental health problems associated. Of course, these are the major things that we see all the time when there's major issues. Anxiety, depression, post-traumatic stress disorder. Unipolar depression is the second leading cause of women between the ages of 15 and 44. Depression precedes first incidence of dating violence. If you look at whether it's an adolescent or a young adult who's been a victim of dating violence, they first inward start to blame themselves. They think that they are responsible for what's taken place. And so therefore depression sets in. And so without them actually talking and saying, this is what happened to me, and understanding that it's not necessarily their fault. And it's never their fault, I say, when somebody else does something to you that constricts you or hurts you. It's never your fault, because that person has a choice. Due to the depressive states of our teenagers, are less selective in choosing a partner and start to, if they have low self-esteem to start off with, they'll accept things a lot easier. So it's been a lot of work in trying to build their self-esteem and their self-worth, especially if they're in a relationship, whether it's a male or female, in a relationship where someone is abusing them. Because not only do we know that our females are in relationships that are abusive, we also know that there are some teen males that are in relationships as well as same-sex relationships. Is another whole research effort that we're looking at now. Depressed teens who couple with individuals displaying poor impulse control are susceptible to violence. And that may mean that they may be diagnosed with attention deficit disorder or not, but they just act on impulse. Let's just go out and have a good time and do something. And then all of a sudden something happens in that situation and that relationship. And so there's a violent act that has taken place. So the same mental health issues that we're consistently dealing with individuals, especially women, are the things that we see most prevalent in those who are victims of IPF. Next slide, please. Okay. Separation is a dangerous transition. Troubling correlation between stalking behavior and subsequent physical violence and murder. Okay, so, and I kind of waited to the end to actually discuss this, because we know that there are violent acts, but if the person continues, like I started off stating, that I can't live without you, will that person take it to the level where they really will do something in order to prevent that person from living altogether? And I think right before the pandemic, I had received 3 calls in Houston alone, where they asked me to come on scene, but we had actually murder-suicides. And it was almost like they were less than a month apart, and it was with African Americans. And we had not seen that increase as far as numbers that fast, or at least it had not been reported in our area. And they were different parts of the city, but they were all in the suburbs. And each, murder-suicide, where some had children that were there in the house at the time. It was three of them all right back to back of each other. Some had an adolescents, and the other one had middle school kids. So they were all ages, and they were considered to be middle-class citizens. So it was really, really odd that it happened back to back. And going and trying to do crisis intervention was something that I was just contacted to do. So, and each relationship, of course, there was a history of violence. There was also a history of stalking that had not been reported, but each one we found out told at least one person, and they were afraid. One young person that was killed, she was in Jack and Jill, and she was afraid to tell everybody that her peers that this is happening to her with her ex-husband. And so the children finally started to talk about it. So we made sure that all of them, eventually had counseling and things of that nature. But it can happen among any socioeconomic status, is what I'm trying to say. It doesn't necessarily mean that we're talking about the low income, or we're missing the middle class, or we're missing the wealthy. So it's across all gamuts. Next slide, please. I should be close to the end. These are just some of the things that we consider to be tactics that we don't want, or we classify as stalking: unwanted phone calls, voice messages, texts, calling and hanging up, cards, letters, flowers, presents, watching from a distance, showing up in places that they know that they frequent, restaurants and things of that nature, and sneaking into the victims' homes, or scaring the victims whenever they thought they were going to be alone. Next slide, please. Additional statistics: women who are more likely than men to report being fearful. 1/19 of men reported they had been stalked in their lifetime. And 1/2 of female stalking victims reported that stalking first occurred before the age of 25. So that puts us in that college age, and puts us in the adolescent years, when people first start dating. We're thinking that dating starts at 16, but in our society now, dating starts a lot earlier, and parents are accepting of it. So like 14 and 13, 14, and 15, before you actually make it to high school. And 26% of all stalking victims reported they were stalked by technological means, which means our computers, our phones, and things of that nature, which is something I talked about in the very beginning, that are the changes from where it was, 20 years ago, 25 years ago. Next slide, please. Okay, we're going to end with that, because that is an example of a cyber stalking possibility that's taking place. Well, we can't see the person on the other side, but we know who that person is, because we're able to see what they're putting out there, what they're putting in their peers, as far as the group texts, or what they're putting out on the internet to actually have an impact. Okay, I think, Dr. Bailey, that's the end of my presentation. I tried to do it in enough time, within the time that you had allowed it. Are there any questions?
Simply excellent. Let's go to questions.
Oh, good. It appears that Dr. Jordan has his hand up.
Dr. Jordan, you're on a roll, guy. I think, Dr. Jordan, I hate to cut you off, but I think you're a closet psychiatrist. So you got his behavior. You got the same patients we have. Go ahead, Dr. Jordan.
Well, two things. One, I had a patient who stalked his wife, and he had both of their kids, ages 2 and 3, sleep in the bed with him. He killed her. He killed himself. And it's just, 12 years later, the kids are still messed up. This is the album of the woman who, it's a beautiful song, but he played it over and over. And my point that I'm trying to ask, how much of R&B that we like, the songs, the theme really is saying, don't leave me. I die if you leave me. I don't know what I'd do without you, etc. And I guess my question is, are we sort of making some folks prepared to do some stupid things like this? Because this is Lorraine Ellison, and Bette Midler has tried to sing her song. Other folks have tried to sing it. Barbra Streisand tried to sing it. Stay With Me is one of the most powerful songs I've ever heard. But you have to ask yourself, why the hell would you beg someone to stay with you?
Dr. Jordan, can I just add to your question? The
Sure.
Stalkers National Anthem, Aretha Franklin, until you come back to me.
Uh,
I'm going to knock on your door, tap on your window pane, sit
Yeah.
by your step. That's really the song that you're talking about. There's something about how we normalize literally stalking behavior. I think it's a really important question, because sometimes we're not listening to the words, but we're listening to the words.
yeah. And that's my question. Thank you.
Awesome. Gosh, you guys, that's a great, I hadn't even thought of, and I sing that song without even knowing the words, you know, because you become accustomed to singing the songs and not really listening to it. Now, mind you, we're looking into the mind of somebody who has obviously a poor self-esteem and self-worth, who may have had some childhood issues growing up, whether they had been abandoned. And so therefore the need of having, or the idea of having someone leave them, and they have control over that situation, what they think to a certain degree, also triggers other things within their personality. So we're looking at personality disorders as well, and an individual. We're not just looking at the normal relationship between a boy and a girl, and he's just upset because she's gone with someone else, or vice versa. We're looking at people that are on the other side of that, who have clearly crossed over to needing psychological and psychiatric help. So it's not the average person can sing those songs and not be totally affected. You may have the blues if you've been in a relationship or something, but when it gets to the point where a person is actually obsessing about the individual. Because remember when I said how the history of stalking, where it used to be where women were the only people they thought that actually had that, and it was on stars. Okay, so which means that if I wanted to have a relationship, I wanted to marry Michael Jackson. Who didn't want to marry Michael Jackson? We thought when we were young. Okay, believe me, I got past that. But when I was young, it was kind of
We
like,
hope so.
oh yes, I guarantee you I did. You know, I had posters in my room, and every young girl, you know, we all thought we were going to grow up and marry somebody famous. But, you know, as time progressed, you realize that wasn't a reality. When you look at a stalker, you see that person who doesn't get past that normal behavior, that normal adolescent growth, that normal development that you're looking for as you look into people. So therefore you have a person that's stuck somewhere. Their mind is starting to think differently. You know, they may not be able to function at work. They may be going to work and have, you know, jobs that are not fulfilling them, or they may marry a woman who's very successful and who they thought that they would be able to handle a relationship with. And as she started to grow, they didn't grow with her. Okay, so for him, it would be to his advantage to keep her down as opposed to allow her to soar, because then that helped, that put something on his self-esteem. And so you start to look at, I always want to get that history, because I want to know where that person came from, because it tells me where they possibly, how they got to where they are. So there are a lot of theories, I think, in the brain of the mind of the development of what did not take place in a stalker. Okay, so therefore, I'm truly a victimless person. Do a lot of work on victims, rapes, children who've been abused, and the whole 9 yards. But when I look on the other side to try to figure out how do we get to that point, then you start to see all the things that person was lacking. Probably undiagnosed psychiatric illnesses that were not diagnosed when they were children. You know, and just the little things that got to the point where he felt as though he needed to maintain control. That he needed to have that. And if somebody left him, his life was not going to, because you got to really think about it. How can somebody love you that much that you're going to love them to death? We say that in our vows, but I shouldn't love you to death. I mean, I'm not going to love you and then I'm going to turn around and kill myself. Okay. And you do know, and I do say this all the time, is that a person who actually does it is under the influence of some type of substance. Okay, so we're not going to say that they're able to do this because the mind is not thinking correctly. And it's usually not psychotropic medications, it's street drugs. You know, whether it's alcohol, whether it's marijuana, whether it's acid, or depending on what part of the country we're in, as far as the type of drugs that they use. Heroin's back on the uprise. So when you do a toxicology report after the end, you look at all the drugs that are in that person's system at the time that they committed that act. And what does it take? You know, I've had one patient call me on a Sunday afternoon, and I told him, I said, in 2 minutes, the police are going to be showing up where you are, because you're telling me that you cannot do anything without your wife, and I need to talk to her. And so I was able to actually get his mother's phone number to be able to get in touch with the ex-wife to let her know that she was under a threat, because he just really was so intense about stating how much he needed her in his life. You know, there's just a lot of things as therapists that we go beyond to make sure that we maintain, but he was using drugs, couldn't keep a job. At that particular time, he was kind of pretty much living in his car. So he was using the children as a pawn between the two of them. I know I've said a lot, but I guess I've been working in this field for so long and I've had so many patients. There's so many things and so many analogies I can pull from as we try to figure out who that other person is. But I think I'm going to stop singing that song, Dr. Walks. I really, I'm going to put that on the back burner, you and Dr. Jordan. I think you guys have kind of opened my eyes. You say every day, if you don't learn something, you haven't done anything well. So that's what I've learned today. But yes, I'll stop at that point.
Dr. Gill, may I ask a question?
Sure.
Absolutely.
First of all, it's difficult for me to live without you, but back in the day, when I got married, we were required to take a blood test to rule out venereal diseases. It sounds like one of the prerequisites to marriage ought to be a psychological profile to figure out what's in that person's head. But is it ever appropriate for a senior figure in a family to stop stalking or approach potential stalkers with what I heard Dr. Bailey say before? If you stalk my daughter, I'm going to kill you, or some other such thing. Is that ever helpful?
Well, now I would hate to be one to say that, but if something happened to my daughter, I think I would clearly be one of those statements I would say. I don't know. It just depends. I didn't know about the blood test, so thank you what you were saying in order.
That was 100 years ago.
100 years ago. Okay. I've only been married 30 years, so I don't remember. I don't remember that. But I don't know, Dr. Bailey, I'm going to yield to that question on you. Let's see if you're able to. And as you're talking, I'm going to try to figure out if I can think of the best answer.
No, I like the point. I'll be brief because I want to get to Dexter, but I also want to come back to Janice Bill. You really brought it today, and I want you to talk about what you do for HISD when the pandemic started before we finish. But I just simply make one comment. I addressed it a little bit earlier by saying this idea that we necessarily don't know what we don't really know. So like Maxie's point, should there be an earlier, like almost a physical exam, if you will, metaphorically, what you do in the 7th grade when you're going to go out for the track team. I made the comment that, so in the old days, you go to high school, you take, these classes, whether it was mechanics or home economics, this idea that we should try to figure out what person's psychological vulnerabilities are makes a lot of sense, because very often you don't know until they are very close to you. We were kind of being a bit jocular about hurting somebody that kind of hurts our daughter. Janice and Dash have a daughter. I have a daughter. Dex is coming next. He's got a son, if you will, alike. But the reality is often you don't know until somebody's inside your family window. They're dating your kid and they're in your house and they visit you for Thanksgiving holidays or what have you. And it may come, Dr. Maxwell, you're right, with some psychological difficulty or some baggage, so to speak, based on their family or how they grew up or what they've seen. And it's remarkably difficult to kind of get past it. It catches your attention once you get that phone call. There's a problem and somebody's in the wrong place at the wrong time and what have you. So I love the idea that we should try to find ways to assess some things earlier. I did by saying we also do with finances. Very rather would you want your kid or like to marry somebody and they're bringing $1 million in debt into your family, you're going to kind of consume it, if you will. But we don't often do enough to understand how they're thinking and functioning psychologically, and I think it is a problem. Tremendous points, Dr. Bill. Let's move to Dr. Samuels, and we get time. I do want Janice to tell you guys what she's done for HISD. Her and Dash have done a very great program. I'm very proud of them for that piece. But let's go to Dr. Samuels.
Dr. Bailey, thank you so much, and the conveners of this just wonderful event. Thank you for your time today. As we close out, I'd like to talk a little bit about my chapter, Violent Childhood, Domestic Violence in Childhood. Let me go to the next slide. I just want you to think for a moment, when you see this child, what do you feel? There's just certain emotions that I see and feel when I look at this child hurting. And children that are going or witnessing IPV have this feeling. It's an emotional feeling. It's a internal feeling that these kids have. And I think it's important for us really to make a difference. And so I'm so thankful for Dr. Bailey for bringing us together. His book is a wonderful book. I always believe that we must leave this world in a better place. And Dr. Bailey is doing that because I think we all need to come together, try to resolve this issue of IPV. Because if we can't do it, who else is going to do it for our children? Next slide, please. So as you know, there's over 10 million children have been exposed to IBV in form of abuse against a parent. We know that there are negative consequences in light of this experience from a mental and physical perspective. We know that witnessing IPV has a higher risk of experiencing IPV as an adult. The parents that are depressed, we know that their children then have behavioral problems and lower cognitive performance. And then also teen dating violence, as you've heard from Dr. Bailey, also can be reduced through educational programs. And this really frames then my introduction and an overview then of my presentation today. Next slide, please. So we know that parents that are depressed, that has a negative effect then on their children. And that there is a strong correlation to those parents that are depressed with IPV, that their kids have ADHD. And then in light of that, they have more academic difficulties. They have lower grades, they have poor school attendance, they have to repeat grades. Unfortunately, they visit the nurses more frequently and are sent home at a higher rate than other children. Then also that they suffer from speech pathology at higher rates and speech incongruency. Next slide, please. Now, one of the things that we've talked about with IPV is a construct of ACEs, which is Adverse Child Experiences. And with ACEs, there is a survey that is done as a questionnaire. And that questionnaire has several different questions from one, do you have anybody in the household that has a drinking problem? Does anybody in the household, have they gone to prison? Any of adult or person in your household, have they humiliated you or have they sworn at you? Then also to Dr. Jordan's point, has anybody in the household touched you inappropriately or fondled you? And then when you look at the effects of these ACEs, there has several different constructs to those effects from a health, from a behavioral and a life potential perspective. And when you look at the number of ACEs on this particular slide, you see then that the rate increased dramatically from the risk of negative health outcomes as you have more ACE score that increases. Next slide, please. Now there's effects on parenting also from parents that experience IPV. One, IPV can send the victim into depression. One, it decreases the quality of you being able to deliver healthcare and care than to your child. We also see that children have a lower weight. They have experiences of difficulty gaining weight and they're more irritable. Also with IPV, depression, substance abuse disorder, it reduces maternal functioning. And then finally, there's an impact on the quality of care and higher risk of developmental disorders with kids that has a negative effect on parenting. Next slide, please. Now here what you see, which is when I first saw this slide, was really astounding when you look at the odds ratio of IPV and health outcomes. And when you look at this odds ratio, you see that it's really relatively low odds when it comes to physical inactivity, diabetes, cancer. But when you look at the last three then health conditions from violence victimization, violence perpetration, and problematic drug use, which we've heard, it's really astronomical in terms of then the odds of and the tendency then of this negative health outcome. Next slide, please. Would you see that 17 to 33% of school-age children have PTSD? Well, we know that there are issues with cleanliness. There's issues with talking and thinking about events repeatedly and reoccurrent nightmares. There's also the children experience interpersonal trauma, is abuse, sexual abuse, and assault. And we know that children who have experienced IPV are 2.5 times more likely to have been physically abused and 5 times more likely to have been sexually abused than individuals who don't have IPV in their household. Next slide, please. Now, this is what we find that kids that have experienced IPV, they self-isolate, they distance themselves from others. There's a lack of social cohesion. And so this is something that we have to address early on. And one of the things that we have to do as practitioners in working with our schools is what are some of the early alert signs? And so we should come up with tools then to address what are some of the early alert signs so we can address these issues on the front end. Next slide, please. Now, we also know that there is a direct correlation to IPV and obesity, that the association between obesity in children and IPV, that 80% of children whose mothers experienced IPV were obese by the age of 5 years old. We know that because of this experience, food becomes a consolation tool by the mother. And we also know that the caloric intake from the children, that they use food as a way to soothe themselves. Next slide, please. We also know that there is impact of childhood trauma, and the CDC and Kaiser Permanente conducted a study of over 17,000 individuals. And what was interesting about this particular study is that 2/3 of the individuals that were surveyed experienced some type of ACEs event. And when you look at this particular slide, you see the increasing likelihood of liver disease and COPD. Next slide, please. And there's a correlation to physical illness and childhood trauma, that we know that IPV subjects children to psychological stress. We know that the stress exposure in the early parts of their life increases psychological responses to the stress. There's insensitive maternal attentiveness to stressed child, disrupts child's immune system, and also increases asthma. As we know that individuals that experience IPV have about 18% likelihood to be asthmatic. And that we also know that there's a high degree of emotional deregulation that occurs because of this IPV experience. Next slide, please. And we also know that for a parent who has IPV and experienced IPV, there's increased likelihood of them becoming perpetrators of IPV. And there's also a direct correlation of the sex of a child that plays a predictive role if they will be perpetrators of IPV. Also, a majority of the IPV perpetrators, unfortunately, are males, and that 20 to 40% of adult males perpetrate IPV at some point in their lifetime. So one of the things that we must do then early on, understanding then this alarming trend, is what can we do to address this, particularly for young males? And one of the things that we've done at Meharry Medical College is we've established a program called ABV. It's aggressors, victims, and bystanders. And how do we address early on if there are tension then between children? How can we address then that tension? What can we do to mitigate then any untoward experiences that those kids are having? And so we've done this in metro schools and it has worked out extremely well. And what we also find is that it has reduced the truancy rate then in the metro schools. Next slide, please. We can also know from violence perpetration that bullying is also another indicator of future IPV experience. And that for children in IPV households, they're more likely to be the next generation of victims or perpetrators. And so how can we then eradicate this trend? And what can we do to ensure that this does not become a generational issue? We also know that 56% of the abused mothers reported children that did not witness IPV. Even though they may not have witnessed IPV, we know that the children are aware that violence is occurring. And then what can we do then to make sure that the children have an outlet? We know that our children at times are non-communicative. And so with peer-to-peer groups is something that has been effective. Also, mentoring program. I know at Meharry Medical College, we have our Meharry students then go to the high schools to mentor high school students and also elementary school students. And we found this to be extremely effective. Next slide, please. We also know when you look at the ACEs score that there's a risk of perpetrating domestic violence. I want to call your attention really to the risk score 3 and above. you'll see that there is an increasing risk as you have a score of 3 or above. But what is alarming in this particular slide is if you look at the men of a risk score of 4, it's almost twice the rate of increase than women of the same score. So this is something that, again, that we have to address from the onset at the early childhood perspective. Next slide, please. And then also we know that IPV has an effect on adolescent women, that IPV puts adolescent girls at risk for utilizing diet pills, laxative pills, and self-vomiting. Also, the young girls have 3 or more sexual partners in the last 3 months. Young girls are less likely to use condoms during sexual encounters, which then can lead to STDs. And there's also more serious contemplation of suicide and suicide attempts also for adolescent girls. And then also, and finally, 10% of intentional injuries to adolescent girls are attributed to males that they were dating. Again, it goes back to Dr. Bailey's reference to teen dating violence and how can we then address this particular issue. Last slide, please. When you look at this, we have to make sure that, from my belief, is that we have to start addressing this as early as possible in the system. We know that school systems are under-resourced, but we have to put forth programming and resources to address this on the front end. We know that IPV has a deleterious effect on our youth. And we know that we have to leave this place in a better place, and that if we don't address it, we know that the trend is such that IPV will be with us for some time. I believe that concludes my presentation. We'll open up to see if you have any questions or turn it over to Dr. Bailey.
Great job, Dex. Let's open for questions.
Well, I have a question, and I don't really expect anyone to have the answer. I don't know if anyone heard the woman testify about the Tulsa massacre before Congress this week. And she's 107. She was 7 years old and was a witness to what happened in Tulsa. And during her testimony, she said she is still troubled by what happened when she was 7. However, when she watched what was going on with George Floyd, and when she watched what was going on January 6th, it was still troubling to her. As a follow-up to that, someone questioned the Attorney General from Minnesota, Keith Elliston, about what was his reaction to her remarks. And he said, and he named her, and I don't remember what the name, but there was a 7-year-old or 9-year-old that witnessed the killing of George Floyd on site. And then countless number of children have seen it on TV. So listening to all that has been said today, and being a pediatrician by training, I can't help but think that if we don't quickly figure out a way to start providing interventions for the younger generation, we're going to see ourselves in a spiraling down in terms of mental health, as well as an increase in violence. And I just open up that to anyone who wants to comment.
Well, my follow-on to Dr. Neighbor's question is, there's so much violence on TV and in games. Is that contributory as well, even though it may be fantasy?
Dr. Neighbors, I could just comment briefly, just from a collegiate perspective. What I'm finding in my experience, particularly at an undergraduate level, that these experiences, IPV experience, manifests itself then in college. And because of that manifestation, the students then have troubles grappling with what they've experienced, and then they have problems learning. And so they can't cope, they have poor coping mechanisms, they don't seek out appropriate resources, they are afraid to reach out to somebody to tell them what they've experienced. And all too often what I've found is that individuals don't get through college because of these experiences.
Is there any relevance to the fact that on some of these violent games, the shooting games, you can kill 10 people, get up and go eat lunch, and there's no consequence to it? Does that translate over into the way we have killings in our communities among teenagers and youngsters as well as old people?
Okay, I'd love to be able to talk, and I promise I won't be long-winded. But I have my own theory about the children and the violence that they've been watching, and how traditionally we've had kids in preschools where in some neighborhoods, violence is considered to be nothing. The kids are not even moved by it. They come and they talk about it. I used to, before the pandemic, I consulted with Head Starts, and I had children talk about it as young as 4 and 5 years of age, seeing somebody get shot. And it was just a matter of fact, oh, miss, I want to tell you about so-and-so. And everybody in the room would have watched it, but nobody appeared to be affected. But that's not the case, because we know when trauma is on top of trauma, we know eventually if you don't deal with it, it's going to come out in a different way. And I think with the George Floyd murder that we saw, I saw everybody in the whole world watch somebody actually lose their life and the life come out of them, which I don't remember we've ever seen that was in real life before, where it was publicized so many times. And so I would tell parents to stop children from viewing it, because they were taking that part in and it was doing something to them. And we had no form of treatment, no form of counseling, no form of talking about how are you feeling, let's talk about it. And when that next person got killed on the Capitol Hill, it was like nobody even thought about it. It was like, oh, okay, she got shot. She shouldn't have been where she was supposed to be. And it's almost, I don't want murder for our kids to become so normal that we don't understand the effects of what that does to the psychic long term. And we do know that we have a traumatized society. We've been traumatized since slavery. And we still are trying to heal the wounds, I think personally, in my personal opinion, of what happened to us a long time ago, that we haven't worked through it to where we are today. So now we're seeing real life murders and real life things that are happening. And we just keep going on as if it's like, okay, that happened at an apartment complex, somebody got shot, the kids didn't talk about it, and we went on to the next thing. So we're gonna have to, at some point, stop and actually deal with it and help people heal from what they've experienced in order to be able to go forward and have healthy individuals and healthy adults grow up. So that when they get to college, they'll be able to function based on what they've experienced in their environment. So we have I think in a long way, and I'm sure please join in with me, because I think this is a think tank, because I always like to hear others' opinions on what they think. It's just my personal opinion as a clinician of working with so many children and working with so many young adults to see how they're actually processing this information. So they're not processing, they just put it underneath, I guess, basically. It's kind of like, oh, that's a part of the norm. Somebody got shot. So it's, I mean, we hear bullets, we jump and we whatever. Some kids hear bullets, they don't even flinch. They hear the ambulance and it's a part of what they hear all the time. So we really have to look at how we can start reprogramming things that people are experiencing, especially our young Black kids in certain neighborhoods. And I hope that Dr. Barbara Stevens, I hope that answers your question a little bit. I'm really concerned about what's going to happen 5 years from now when we pass George Floyd and we stop talking. But I think every time with television, I was on TV recently and I told them to please stop playing things over and over and over again. Because the only thing that does is reintroduce it for our young kids. And if they can't, then please let the parents stop letting them watch things of that nature.
And I think you understood right. And all I would add is that I think that in addition, our society, the one that we live in, has made it, carte blanche to devalue a Black life. And I think we have to kind of acknowledge it. Those same kids that are in my practice, like yours, Janice, they respond differently because of what society has taught them. On television and the media, mentioned the radio and the news and the like, if a young Black man is killed, whether it's Michael Brown in Ferguson, Missouri, killed in the street and laid there for 4 hours, versus if a white person is killed, if a police is killed, if a white woman, I often said in my group, and I'll let you be disrespectful, but if the same things happen to a 50-year-old white woman that happen to 25-year-old black men all over the place, all over the news with the police and et cetera, everybody in society would stop and respond differently. The police act differently, the ambulance acts differently, when you go to court, the judge acts differently, the hospital act differently. So I think that we have to, call that spade a spade and acknowledge that our society must value a black life, even if it is male, even if the person is young, no matter how they wear their hair or how they wear their pants. And to the extent that we don't, we send a message that I think you make a great point, Janice Beal, society picks up on, and young children pick up on it in a different way and express it in a different way and perpetuate it, which I think is fair.
So let me jump in. I think we could stay on this particular aspect of the topic we're on now for about the next 2 hours. We have moved from interpersonal violence to talking about violence in general. And I think we have a Black Health Trust program coming up looking at deaths in custody. One of the things that Dr. Nabrit Stevens and I are supposed to do, one of our jobs on Sundays, is to look at what's in the chat. And there's a statement in the chat that has me feeling like I need some personal time with either Dr. Guyan or Dr. Beal or Dr. Bailey or someone, because the question is, if the police are defunded, will the therapists then step up to help the public deal with the mental health issues? Stop. The police do not help the public deal with the mental health issues. It's not what the police are called to do. The police are there to supposedly keep things safe. So I just want to make sure that as we're talking, we're not just accepting things that are made as statements of fact. I don't believe, maybe I'm wrong, that defunding the police has anything to do with therapists stepping up to help with mental health issues. And I just think we need to address that particular statement. Dr. Bailey, if you could take that, and then I can calm down.
I will in 30 seconds, and I definitely want to give Dexter and Janice a chance to jump in. All people should appreciate, and therefore educated Black people on this show must acknowledge and appreciate that all defunding the police really means is defunding the guy with the gun who shows up for a non-violent complaint or construct. The same amount of money could actually be used from government coffers, but some could be transitioned or rearranged to go to persons like a psychologist, Dr. Janice Beal, or psychologist, like Dr. Guyan and Dr. Samuels, who show up with the skills needed to manage a non-violent offense, conflicts and domestic issues and interpersonal engagement and these teen dating issues, if you will. There's a lot that in the mental profession we could do, but when a guy shows with the gun, it changed the entire dynamic. And if you show with a gun and you already are unfortunately via algorithms predisposed via media thinking differently about the person you're going to see who's complaining, if it's a young Black male than others, then that's just that's the worst hot sauce, if you will, of what may end being violent from the law enforcement government official toward the young individual. Defunding the police was never about having any less money being spent. It's just rearranging it and put it in the hands of people who are professionally trained to manage these kind of interpersonal conflicts. But I'll defer to my two co-panelists for their comments as well.
I think you said it all, Dr. Bailey.
Yeah, I think you said it all.
So, Dr. Bailey,
Yes.
I had a call from your secretary this morning, and she told me that you wanted to do 2 more sessions. And I said, absolutely. And we'll look forward to signing that agreement tonight. This has been so outstanding, as have the other 3 have been. And I appreciate the speakers, the information and the quality. And you have helped put us on the map. So we appreciate what you have brought. And we'll look forward. And I'm gonna have Dr. Walks reach out to you. We need to schedule those other 2 shows that you demanded that we have.
Absolutely.
So either your book's got to get longer or something.
Doctor, I appreciate you.
Okay. I want to remind everybody that we are now a 501c3, and we urgently need any support that you feel moved to give us. We have a website, blackhealthtrust.org, and we'd appreciate you looking at that, and it's growing every week. We're putting information and resources. All of our speakers are listed, and you can also view past programs almost immediately after the program's over. We're also on YouTube, and we're trying to grow and get more information out to communities of color. We also have a program called Biometrics secondopinion.com, where many of the speakers that you see on this program weekly are consultants, and we're there to serve people who wish to upload their medical record for a second opinion consultation. And we appreciate that. We have other benefits that we're going to bring to the table as soon as possible. And we thank you so much for being. I appreciate the great speakers, outstanding speakers, and we learned a lot. Dr. Barbara,
I can squeeze one thing in. I want to give Dr. Janice Beal a comment, a chance to make a comment. I think she's got a great program in Houston. You give her 30 seconds, Dr. Max, I really appreciate it.
Go right ahead. Dr. Beal?
Okay, really fast. I just wanted to share with everybody. The STEAM Fund has commissioned me to be able to do a program for mental health for children of color, adolescents of color. And so it's a 5-week program. It's free. Anyone can join. If you have someone that you want to recommend to be a part of it, we're coordinated, and I've developed a curriculum, and it just talks about mental health, and we're trying to reduce the stigma among children of color. So it's a 5-week program. It's not 5 weeks, it's just 5 hours. Let me start using that time. It's a 5-hour, and we can do it in 1 week, or we can do it in 1 day, or we can do it 5 weeks consecutively. And so it's a peer and mental health professional type curriculum. So where we're talking about what is mental health, what are some of the signs of mental health, what is racism and what the impact has it on mental health, and how we can improve their mental health. So it's just, and they become participants, they watch videos, they talk. And so if anyone is interested, please contact me and we can sign those young people up. Doesn't matter what city, because it's a virtual program. So we're doing it right now. I'm doing it in New York. And so we're going to start in Houston next week. And so we're going to go throughout the summertime. And my goal is to reach 625 young adults between the ages of, well, I guess really youth, between the ages of 14 and 18 years of age. So the only thing they have to do is commit. So if you have someone, or you have a group, or you know of a group that we need to contact, we'd be more than happy to try to provide that service for them.
Dr. Beal, could you put your contact information?
Sure.
In the chat?
Okay.
And if anyone doesn't have an opportunity to capture her contact information, please feel free to contact us at Black Health Trust, and we'll facilitate the hookup.
Dr. Beal, I'm going to encourage you to put together a 5-week program for those of us who are grandfathers of some of these children who are having these problems. We need it too, so we can enforce it. Dr. Neighbor-Stevens, you have some words?
Today, I think we have again, we have been given the opportunity to hear information that we're not going to easily find in other places. Please spread the word among your social network about the great opportunities that Black Health Trust continues to try to bring to the community. I see a grandchild has arrived. You know, help us spread the word so that we can get our message out.
Dr. Walks?
I would like to thank Dr. Bailey again. Many times, especially in communities of color, mental health is not something we talk about. Mental health is in the background. It's not part of what is an ordinary conversation. And what Dr. Bailey and Dr. Samuels, Dr. Beal, Dr. Guyan, what we've had an opportunity today to understand better is just how comprehensive an opportunity mental health is. Mental health is more than just going to the doctor's office. It impacts every single aspect of our lives and all of the other kinds of health challenges that we have. So I just want to thank Dr. Bailey again for his leadership in helping folks understand that mental health is important, and mental health understanding and mental health treatment is relevant in our community. In all of our communities, we need to understand that people like Dr. Beal, Dr. Samuels, Dr. Guyan, and I'm going to say those names again because these are people that are working closely with Dr. Bailey. There aren't these lines between MD and PhD and everything else that we may think. There's a comprehensive approach that Dr. Bailey has been showing us with now this third program that we need to take to heart. So thanks, Dr. Bailey. Thank you, Dr. Maxey.
Thank you so much. Again,
I could help show him off a little bit. I got a grandboy here today, so it's gonna be a good day today. And I can't thank you guys enough, and I thank you, Dr. Maxey, for 2 more shows. We got more people who haven't presented yet, so I really appreciate it, and we'll do 2 more with you. And you like it.
Good. So I'd like to thank our virtual assistant who strives very hard to bring the information to the screen, and our assistant, our production person, Mr. Simon Cooper. And we appreciate the 2 of you working so much, as well as my 2 co-moderators. And on some of our Sundays, we have 2 alternating hostesses that we're glad to work with. We have a steering committee that works hard with us, and we have special advisors to that steering committee and board, including Mr. Carl Brooks, Mr. John Sedukas, Pastor Pointer, and we appreciate their joining us and assisting us back line. I'd like to have Pastor Pointer give us our final word today, and I understand Acts 2 is the operant the scripture for today, and Ms. Brenda Yeager, I would like her to have a musical note prior to Pastor Pointer if she's available.
I did not see Sister Yeager today, and I
Okay.
miss her greatly because she always blesses us so. Dr. Bailey, I want you to know that Dr. Maxey rescued you. I took great umbrage what you characterized in the beginning of this program as the final of 3. I said to myself then, he doesn't realize we still need him to do what he has done, which is give us information that all of us can use in the various work that God has set us to. Things you shared with me today, I'm dealing with at least 2 young women in our community who are in the exit stage of intimate partner violence. Today gave me some additional information to help them and their families, protect them as we go through this exit stage, especially since it was so keenly pointed out that this is a very dangerous coming year. So then I'll know instantaneously to be vigilant and to keep those families vigilant, because we don't want to do funerals for young women, and both of them are under 30. So thank you so keenly for your work and for what we'll see in the coming 2 programs. So let me just thank you for that. Let's ask God's blessing. Eternal Lord, our God and our Father, on this Pentecost Sunday, we bow humbly before you, thanking you for your great majesty toward us. We thank you, O Lord, for sending us yet again, your servants, Dr. Ron Bailey, Dr. Janice Beal, Dr. Dashiell Ginn, and Dr. A. Dexter Samuels. Thank you for sharing with us the gifts that you have allowed them to cultivate. Thank you for enlightening us as we move forward. So then show us, oh God, what we would do that would be pleasing in your sight, and how we would implement these intellectual tidbits into our daily work, that we could protect your people better, that we could love your people better, that we could help your people better. We know that you're able to do all things. And now, as we celebrate again the other gift after the resurrection, there comes the gift of the Holy Spirit, the advent into the world, not as a first time, but specifically as a protector, as a teacher, as a guide. So we thank you for the Holy Spirit and for celebrating the Holy Spirit today. So now the grace of the Lord Jesus Christ and the love of God and the communion of the Holy Spirit be with you all. God bless you all, and amen. God bless you.
Amen.
This has been great.
Amen.
Thank you so much.
Amen.
Dr. Maxey,
Good
you're the
night,
best, man.
everybody. And thanks
Simon
to
Walks, a real
Dr.
guy.
Walter Faggot, my teacher and mentor.
All good.
Have a good night. Simon?
All right.
Everybody
Good night,
blessings.
everyone.